Welcome to the deep dive. Today we're tackling a really complex and often misunderstood area, Lyme disease.
Yeah.
Specifically, we're looking at the ongoing discussion around what some people call chronic Lyme disease
Mhm.
and the alternative treatments that some patients look into, particularly hyperbaric oxygen therapy, HBOT.
It's definitely a subject that sparks a lot of questions, quite understandably. People want clarity.
Right.
Maybe they're affected directly or know someone who is, or they're just, well, trying to make sense of all the information out there.
Absolutely.
So our mission with this deep dive really is to explore the controversy, look at the evidence around HBOT for Lyme and this so-called chronic Lyme.
Using the research that's available.
Exactly. Trying to understand both the science and the patient viewpoints and, figure out where the evidence actually stands right now.
Okay, sounds good. To really get into this, let's maybe start with the basics, lay the groundwork. What exactly is Lyme disease?
Okay, so Lyme disease is fundamentally a bacterial infection. The bacteria is called Borrelia burgdorferi.
Yeah.
And it spreads to people through the bite of infected ticks, specifically black-legged ticks. It's actually the most common illness spread by vectors like insects or ticks in the U.S.
The most common. Wow. Okay. And what are the first signs? What should someone look out for?
Well, the classic hallmark early sign is something called erythema migrans.
That's the bullseye rash.
That's the one, yeah.
Yeah.
It appears around the tick bite in maybe 70 to 80% people get infected.
Okay.
Usually pops up between 3 and 30 days after the bite, and it can get pretty big, sometimes up to 30 centimeters across. So it's quite a noticeable rash usually.
That is big. Very distinctive. Are there other early symptoms that might go along with that rash?
Yes, definitely. Alongside the rash, or sometimes even without it, people might get fever, chills, headache, just general fatigue, muscle and joint aches. Swollen lymph nodes too.
It sounds a bit like the flu almost.
It can, yeah.
Mm-hmm.
And if the infection isn't caught and treated early, later on, more serious issues can develop.
Like what?
Things like additional rashes appearing elsewhere on the body,
Mm-hmm.
pretty severe arthritis with joint pain and swelling, sometimes facial weakness that's known as Bell's palsy, and even heart palpitations.
Okay, so it can get quite serious if left untreated. How do doctors typically figure out if someone has it? How is it diagnosed?
Well, the CDC recommends a specific two-step blood testing process.
2 steps.
Yeah. It starts with an initial screening test called an ELISA. If that one comes back positive or borderline,
Uh-huh.
then it's followed up with what are called Western blot tests. They do both IgG and IgM Western blots, looking for specific antibodies the body makes against the bacteria.
Okay, ELISA, then Western blot. Sounds straightforward enough, but I think I've heard there are issues, limitations.
That's right. There are definite limitations. The tests, especially early in the infection, can have pretty low sensitivity, the IgM Western blot in particular.
Meaning it might not pick up the infection even if it's there?
Exactly. Someone could have that classic bullseye rash, clearly Lyme, but still test negative, particularly in those first few weeks.
Huh. So a negative test doesn't automatically mean you don't have Lyme early on?
Correct. It's a real challenge for early diagnosis.
Yeah.
And another thing, this testing might not be as reliable if someone got Lyme disease outside the U.S.
Oh, why is that?
because there's more diversity in the Borrelia species in places like Europe. The U.S. tests are primarily designed for the strains common here.
I see.
Plus, the CDC and FDA have warned against using some other types of lab-developed tests you might see marketed because they can sometimes give false positives, maybe due to lab issues.
Right. Okay, so the testing isn't perfect. What about treatment then? What's the standard medical approach if Lyme is diagnosed?
If you catch it early, antibiotic treatment is generally very effective.
Good.
Usually a course lasts about 14 to 30 days. For most people, maybe 80 to 90%, this cures the infection.
That's a pretty high success rate.
It is. The common antibiotics used are doxycycline or ceftriaxone for adults and often amoxicillin for kids.
Okay.
But, and this is important, there's still that 10 to 20% of patients who might have different outcomes. Their symptoms might linger, or they might not feel completely back to normal.
Ah.
So there's definitely still a need for more research to fully understand why that happens and how well antibiotics work for everyone in the long run. Some people do experience persistent symptoms even after finishing treatment.
Okay, and that leads us right into a really crucial point, doesn't it? This whole distinction between what some people call chronic Lyme disease and what the medical community usually refers to as post-treatment Lyme disease, or PTLD. sometimes Post-Lyme Disease Syndrome,
Yes,
PLDS.
that distinction is key. So in the medical and scientific world, when doctors say chronic Lyme disease, they typically mean an active, ongoing infection that hasn't been cleared.
Okay, active bacteria still present.
Right. Whereas PTLD, or PLDS, that describes a situation where someone had a confirmed case of Lyme, they got treated with antibiotics, but they continue to have symptoms afterwards.
Lingering symptoms?
Yes. Things like persistent fatigue, muscle and joint pain, sleep issues, maybe cognitive problems, brain fog, and even depression, lasting for more than 6 months after they finish their antibiotics.
So it's about symptoms continuing after the standard treatment, not necessarily an active infection still going on.
That's the current medical understanding, yes.
Right.
When many patients and advocates use the term chronic Lyme, they're often referring to these persistent symptoms, regardless of whether an active infection is thought to be present. But medically, chronic implies ongoing infection. It's a source of a lot of confusion.
I can see that. So just to be clear, the medical view is that PTLD, PLDS symptoms aren't caused by live bacteria still hanging around?
Pretty much. Now, it is true that if Lyme goes untreated for a long time, the infection can persist and potentially affect the nervous system maybe in 10–15% of untreated cases. But the non-specific symptoms we see in PTLD, PLDS, the fatigue, the aches, the brain fog, the current scientific consensus is that these aren't caused by ongoing damage from active Lyme bacteria after standard treatment.
But I've definitely heard discussions, maybe online or from patient groups, about the Lyme bacteria being able to sort of hide or change form, making it resistant to antibiotics. Is there anything to that?
Well, there have been studies done in vitro in the lab, basically.
Right, in test tubes.
Exactly. And those lab studies have shown that Borrelia burgdorferi can take on different forms, like these round body forms or form structures that look a bit like biofilms. And yes, in the lab, these forms seem to be more resistant to antibiotics.
Okay, so it can happen in the lab.
It can.
Okay.
However, and this is really the crucial point, there's currently no solid clinical evidence showing that a persistent, viable infection with Borrelia burgdorferi continues in humans after they've had a standard course of antibiotic therapy.
No proof in actual patients.
Not for persistent infection causing PTLD, PLDS symptoms. What have been documented is reinfection getting Lyme disease again from a new tick bite, sometimes with a different strain of the bacteria, but not the original infection sticking around indefinitely after treatment.
Okay. Despite that lack of evidence for ongoing infection, there's this strong belief among some people, right, that the answer for these lingering PTLD, PLDS symptoms is just more antibiotics. Longer courses or repeated courses?
Yes, that belief is definitely out there and strongly held by some. But current medical guidelines from major health organizations strongly recommend against using extended or repeated antibiotic courses for PTLD, PLDS.
Why is that?
It's based on several well-conducted studies, including randomized controlled trials funded by the NIH, the National Institutes of Health.
Okay, the gold standard trials.
Right. And these trials consistently showed that giving more antibiotics, especially intravenous ones, didn't actually help improve those persistent symptoms compared to a placebo.
Didn't help.
No. And worse, prolonged antibiotic use, particularly IV antibiotics, can carry significant risks and serious side effects.
Such as?
Things like serious bloodstream infections related to the IV line, C. diff colitis, blood clots. Really nasty stuff sometimes.
Wow. So the risks outweigh any potential unproven benefit.
That's the conclusion from the evidence we have. Now, some advocates argue that those original trials had flaws, maybe in how they selected patients or measured outcomes. But even considering those arguments, there just isn't credible, high-quality evidence to support using repeated or long-term antibiotics for PTLD, PLDS. The medical consensus is pretty firm against it due to the lack of benefit and potential for harm.
Okay. So if standard antibiotics clear the infection but don't always resolve the lingering PTLD symptoms and more antibiotics aren't recommended, it makes sense why patients would start looking elsewhere for alternative therapies.
Absolutely. It's a frustrating situation for people experiencing those ongoing symptoms.
And that brings us back to hyperbaric oxygen therapy, HBOT. Before we dive deep into HBOT, though, are there any other established treatments for Lyme itself besides antibiotics? Or anything on the horizon?
Well, for the active infection, antibiotics are really the only confirmed treatment. There was a bit of a complicated history with Lyme vaccines.
Oh, yeah, I vaguely remember something about that.
Yeah, a couple were developed back in the 1990s, but eventually taken off the market for various reasons,
Yeah.
including concerns about side effects and waning public demand.
Right.
But more recently, there's been some promising research on a new vaccine candidate. It targets a protein called OspA on the bacteria's surface. Early trials in healthy adults look pretty good.
That sounds hopeful.
It does, but we definitely need larger studies, especially including people who actually had Lyme before, to really confirm if it's safe and effective long-term. So, something to watch, but not available yet.
Okay. So back to the alternatives. Let's really focus on this idea of chronic Lyme disease as understood by patient advocates. How does their definition differ from the PTLD, PLDS we just talked about?
Right. So the concept of chronic Lyme disease, or CLD, as it's often pushed by advocacy groups, has kind of evolved. It's often used to describe this condition of ongoing, often debilitating symptoms
Okay.
in people that may or may not be directly linked to a persistent Borrelia infection.
Yeah.
It's seen as distinct from, say, a long-term untreated infection,
Yeah.
and also distinct from PTLD, PLDS, where symptoms persist after treatment. It's a broader category for some.
So it's less tied to the confirmed presence or absence of the bacteria after treatment, more about the symptoms themselves?
Often, yes.
Yeah.
And part of the reasoning behind the CLD concept stems from those perceived issues with the diagnostic tests we discussed earlier.
The reliability problems.
Exactly. Advocates often point to the unreliability, especially early on, or the difficulty in definitively proving the bacteria is completely gone. They might mention how Western blot results can fluctuate, or antibodies might be hidden in immune complexes. And this leads some to argue that maybe the clinical picture, the patient's actual symptoms, should be given more weight in diagnosis and management, perhaps even more than the test results in some cases.
I see. It really sounds like, as you said, a divide in perspective between patient groups and the mainstream medical view.
It really is. CLD, defined this way, is primarily promoted by these advocacy groups, not by the broader medical and scientific community.
Can you give an example of how this perspective is represented?
Sure. There was a large patient survey conducted by LymeDisease.org back in 2015. They got over 6,000 responses.
Wow, that's a lot.
It is. Most respondents said they were diagnosed by a physician, and a large majority, like 81%, also had lab confirmation. But here's the thing. 78% reported delays in getting diagnosed, and a huge number, 97%, reported persistent symptoms even after treatment. 90% felt short-term therapy failed them.
That sounds like a lot of frustration.
Absolutely. Now, from a scientific standpoint, the survey had limitations. The methodology wasn't fully described, making it hard to interpret definitively, and it didn't really address the possibility of reinfection.
Right.
But it does provide really valuable insight into the experiences driving these advocacy efforts and the very real suffering many patients report. It highlights why they might embrace the CLD concept.
And that survey also mentioned something interesting about misdiagnosis, didn't it? Conditions like chronic fatigue syndrome or fibromyalgia.
Yes, that's a really key connection. Many respondents reported being initially diagnosed with things like mood disorders, chronic fatigue syndrome, CFS, fibromyalgia, or rheumatoid arthritis before eventually getting a Lyme diagnosis. And there was another study, this one in British Columbia, where Lyme isn't very common. They looked at patients suspected of having CLD. All of them tested negative for Lyme using standard tests.
Okay.
But their symptom patterns looked very similar to patients who have chronic fatigue syndrome.
Interesting.
Yeah, and considering that Lyme tests generally become more accurate the longer someone has been infected, this finding kind of bolsters the medical skepticism about CLD as a distinct entity, separate from conditions like CFS or PTLD, PLDS, especially when reliable tests are negative.
So we've got this really polarized situation, suboptimal tests, treatment limitations for persistent symptoms, and this fundamental disagreement about whether CLD, as defined by advocates, even exists. It creates a real dilemma.
Exactly. The elephant in the room, as some sources put it, is how do you treat a disease that may or may not actually be the underlying cause of the symptoms?
Right.
And it's precisely this complexity, the varied nature of Lyme and post-Lyme symptoms, that has driven patients, especially those maybe with unconfirmed diagnoses or those identifying with CLD, to seek out alternatives.
Like HBOT.
Like HBOT. Researchers actually identified over 30 different non-antibiotic treatments being marketed for Lyme, many without much or any support in the medical literature. HBOT is one of those that's been reported, though somewhat sparsely, since the 90s for patients with CLD-like symptoms.
Okay, so now we're really at the core of it. HBOT for Lyme disease and this contested CLD. What's the official stance? Is this an approved treatment?
No, it's not. Neither Lyme disease nor chronic Lyme disease is an approved indication for hyperbaric oxygen therapy, not by the main professional body, the Undersea and Hyperbaric Medical Society, or UHMS,
Okay.
and not by the FDA, which regulates how medical devices like hyperbaric chambers can be marketed.
Yeah.
In fact, the FDA considers promoting HBOT specifically for Lyme to be misleading advertising under federal law.
Okay, so officially it's a no-go for Lyme, but you found clinics doing it anyway.
We did. Our source material involved online searches, which identified over 100 clinics, 106, to be precise, across 29 U.S. states that were either promoting or providing HBOT for Lyme disease.
Over 100 clinics, despite it not being approved. That's surprising.
It is quite a disconnect. And what's even more interesting is the geographic distribution.
How so?
Well, Maine has the highest incidence rate of Lyme disease in the entire country, right?
Yeah, it's a major hotspot.
Yet, the search found no clinics in Maine promoting HBOT for Lyme.
None. Huh.
But then you look at states with much lower Lyme rates, like California and Florida. They had the most clinics, doing this 42 clinics between them. Nearly 40% of the total found.
That seems counterintuitive. More Lyme, fewer clinics offering this unapproved treatment, less Lyme, more clinics.
It does seem strange at first glance, but it might hint at something.
Like what? Any theories?
Well, purely speculating based on the data. Perhaps in high-incidence areas like Maine, doctors are just more familiar with Lyme. Diagnosis might be quicker, standard treatment protocols may be more consistently applied and effective early on.
Meaning fewer people end up with really persistent, difficult-to-manage symptoms searching for alternatives.
Possibly.
Mm-hmm.
Whereas in low-incidence states, maybe there are more diagnostic delays, more uncertainty, perhaps more patients feeling let down by standard care, leading them to seek out alternatives like HBOT more readily. It kind of echoes those survey findings about diagnostic delays being common, especially outside endemic areas.
That makes a certain kind of sense, a complex picture. Now, even though it's not officially approved, what's the scientific rationale? Why would anyone think HBOT could work for Lyme? What's the proposed mechanism?
Okay, the thinking behind it relates to how oxygen affects bacteria and the immune system generally.
Right.
We know our immune cells use oxygen, creating reactive oxygen species and what's called an oxidative burst to help kill bacteria. And studies have shown that low oxygen levels in tissues can actually hinder the function of key immune cells like neutrophils, which are crucial for fighting infection.
So more oxygen might help the immune system work better.
That's the idea. Research in other conditions, like osteomyelitis bone infections, has shown that boosting tissue oxygen levels can indeed enhance neutrophil function.
Okay, that's for general infections. What about the Lyme bacteria, Borrelia burgdorferi specifically?
Well, lab studies on B. burgdorferi cultures found something interesting. The bacteria became less infectious when exposed to oxygen levels, similar to what we breathe normally at sea level.
Okay.
But they could still survive quite well at much lower oxygen levels, the kind you might find deep in tissues. This suggests just breathing normal air probably isn't enough to suppress the bacteria inside the body.
Right. So how does HBOT change that?
During HBOT, you breathe pure, 100% oxygen at increased atmospheric pressure, often around 2.36 normal pressure or 2.36 ATA.
Much higher pressure, much more oxygen.
Exactly. This dramatically increases the amount of oxygen dissolved in your blood plasma and forces it much deeper into tissues, reaching levels far beyond what normal breathing can achieve. The inspired oxygen pressure can be almost 1,800 millimole Hg, leading to tissue oxygen levels potentially around 300 millimole Hg.
Compared to what normally?
Normally, tissue oxygen is much lower, maybe around 30, 40 millimole Hg or even less in some areas.
Big difference.
Huge. So the theory, going back to the 90s, is that these significantly elevated oxygen levels achieved during HBOT might directly inhibit or suppress the B. burgdorferi bacteria.
Okay, direct effect on the bacteria.
Possibly. And combined with the idea that our immune cells, like those neutrophils, might function better at these higher oxygen levels. Well, that combination is the proposed rationale for why HBOT could potentially help in Lyme disease.
Any other proposed mechanisms?
There's also been some suggestion, based on other research, that immune cells in some Lyme patients might have issues with their energy production, specifically mitochondrial dysfunction. HBOT, by delivering more oxygen, could potentially help address that cellular energy deficit.
Okay, so there's a plausible biological basis, at least in theory. But what about actual evidence? What do the studies show for treating Lyme or CLD with HBOT?
Right. Theory is one thing, evidence is another. The most frequently cited work comes from a pilot program run at Texas A&M University back in the 1990s.
Okay, that early one.
Yes, they took a series of patients who had confirmed Lyme diagnoses based on CDC criteria, but who had actually deteriorated or failed to improve significantly during or after standard of IV antibiotic treatment.
So, likely people who would fit the PTLD, PLDS category today.
Exactly. These patients received a course of HBOT, typically up to 40 sessions, each lasting an hour, at that 2.36 ATA pressure.
And what happened?
Well, one interesting finding was that almost all of them, within the first few days, developed what's called a Jarisch-Herxheimer reaction.
A Herkix reaction. I've heard that term.
Yeah, often shortened to Herx. It's this temporary worsening of symptoms, muscle aches, chills, low-grade fever, thought to be caused by the immune system reacting to toxins released by dying bacteria. In this study, it lasted a couple of weeks for most.
So maybe a sign that something was happening immunologically?
That's what was suggested. And then, after the Herkitz reaction subsided, the study reported that the vast majority, 37 out of 38 patients, showed improvement or even resolution of their Lyme symptoms within about 3 weeks after finishing the HBOT course.
After finishing, not during.
Primarily after, though some improvement might have started during. And remarkably, this improvement was reported to be sustained in about 70% of them for up to 6 years after treatment.
6 years. That's quite something. Any ideas why the benefit was delayed?
The researchers hypothesized it might take time for the body to dial down chronic inflammation and the sort of cytokine hyperactivity that might be contributing to the persistent symptoms. Patients also reported cognitive improvements, better thinking, concentration, and less depression.
That sounds very positive, but it was a case series, right? Not a randomized controlled trial.
Correct. It was a pilot program, a case series. Important preliminary data, but lacks the rigor of an RCT with a control group.
Were there specific examples shared?
Yes. The report detailed 3 individual cases. All were women, none had the initial rash, but all were diagnosed via blood tests. They'd had recurring or persistent symptoms for years, really impacting their lives. One had to leave school.
Long-term sufferer.
Yes. 2 lived in Lyme-endemic areas, and 1 might have had recurring infections. All 3 reported significant improvement 5 months after finishing HBOT, and 2 noted improvements starting during the treatment itself.
Okay, so that's the main pilot study. Is there anything else? Other evidence?
It's fairly limited. There's a single case report from Taiwan of a patient with recurring Lyme and persistent neurological and musculoskeletal symptoms who reportedly resolved after 30 HBOT sessions.
One case report.
Oh, yeah.
Yeah.
Then there's a potential connection to fibromyalgia, FMS.
Right. You mentioned that overlap earlier.
Yes. Some patients with CLD-like symptoms also fit the criteria for FMS, and there has been research specifically on HBOT for FMS. One prospective crossover trial showed significant improvements in FMS symptoms after 40 HBOT sessions.
A crossover trial is pretty good design-wise.
It is. Both the group getting HBOT first and the group crossing over later showed benefits. They even used SPECT brain imaging, which suggested changes in brain activity related to pain processing neuroplasticity.
Interesting. But any caveats?
Yes, a notable minority, about 29% of the FMS patients in that trial, actually felt worse initially, with intensified pain during the first 10-20 HBOT sessions, before eventually improving.
So not necessarily smooth sailing, and maybe not for everyone.
Right. It suggests more research is definitely needed to understand HBOT's role, especially for CLD patients who also have FMS symptoms.
Okay. Any other angles? I think our source mentioned hearing loss.
Yes, that was quite intriguing. There are a few reports linking Lyme disease to sudden hearing loss, which then responded positively to HBOT.
Huh. How does that work?
Well, idiopathic sudden sensorineural hearing loss, ISSHL, basically sudden unexplained deafness, is actually one of the established UHMS-approved indications for HBOT.
Oh, okay. So HBOT is approved for that specific type of hearing loss.
Yes. And interestingly, some research found that the prevalence of B. burgdorferi infection was significantly higher, like 6 times higher, in a group of patients who experienced sudden hearing loss compared to controls.
Suggesting Lyme could be an underlying trigger in some cases of ISSHL?
Exactly. There was even a case report of a patient whose only symptom of Lyme was sudden hearing loss. They improved with HBOT and corticosteroids initially, and then later antibiotic therapy fully restored their hearing and confirmed the Lyme infection was cleared.
Wow. So in rare cases, HBOT might be treating Lyme indirectly by treating an approved condition, ISSHL, that Lyme caused.
That seems to be the implication in those specific reports. It adds another layer of complexity.
Definitely. So, given all these different pieces, the pilot study, the case reports, the FMS link, the hearing loss connection, is there any consensus on how HBOT should be used for Lyme or CLD, like a standard protocol?
No, not really. That's one of the big unknowns. What's the optimal regimen? How many sessions? How long should each session be? At what pressure? Should there be breaks? We just don't have solid answers to those questions based on the current evidence for Lyme or CLD specifically.
It really underscores what you said earlier, a real lack of comprehensive data, especially considering how many clinics seem to be offering it.
It's quite troubling, actually. You have potentially a significant number of patients receiving this treatment for CLD,
Hmm.
promoted quite strongly by some clinics and advocacy groups.
Uh-huh.
Yet there's very limited published data on safety and efficacy specifically for Lyme, and the underlying condition, CLD, remains highly debated.
It's a strange situation.
It seems clear that HBOT is valued by a subset of patients, often those with these persistent, nonspecific symptoms, sometimes with unconfirmed infections. But for HBOT to gain wider acceptance, maybe insurance coverage,
Right. Insurance is key.
you really need more robust research, especially randomized controlled trials. But as we mentioned, the financial incentive for large pharmaceutical companies isn't really there for something like HBOT. They're focused on drugs, antibiotics.
So without big trials, how do we get better data? Our source mentioned this idea of a medical registry.
Exactly. A dedicated HBOT medical registry for Lyme and CLD could be a really valuable step.
How would that help?
Well, first off, it would immediately give us a much clearer picture of just how many patients are actually being treated with HBOT for these conditions. Right now, we can guess at the number of providers from web searches, but we have no idea about patient volume or outcomes.
So just getting the numbers would be a start.
A huge start. And a registry could collect outcome data. It could potentially help shed light on that regional disparity we talked about. Are there really more undiagnosed or misdiagnosed cases in less endemic areas leading people to seek HBOT? There was a study in Tennessee, for instance, that found Lyme incidence reported by private labs was way higher than official public health reports, suggesting significant underreporting. A national registry could help clarify confirmed versus probable cases, misdiagnoses, and treatment patterns.
Okay, makes sense. How would it work practically?
You'd need some groundwork.
Yeah.
An established, defined treatment protocol, ideally approved by a central institutional review board, an IRB, that oversees research ethics.
Okay.
Then, participating clinics would need their own IRB approval, and crucially, patients would have to provide informed consent to have their data included.
Right. Patient consent is vital.
Absolutely. The registry would collect anonymized data on patient characteristics, their treatment details, and most importantly, their outcomes over time. Analyzing this data could help refine treatment protocols, maybe identify patient subgroups more or less likely to benefit, provide more evidence on efficacy or a lack thereof, and generally improve our understanding of these patients and how best to manage their symptoms.
It sounds like a way to gather real-world evidence when RCTs are scarce.
Precisely. It's not perfect, but it's a pragmatic way to address the current knowledge gap.
Okay. So let's try to pull this all together. After this deep dive, what are the main takeaways about HBOT for Lyme disease and chronic Lyme?
I think the key points are these. HBOT is something valued by some patients dealing with persistent symptoms after Lyme treatment or those who suspect they have Lyme or CLD.
Right.
But, and these are big buts, it remains an unproven, unapproved indication. Lyme itself isn't an approved use, and the very concept of CLD is highly controversial in the medical community.
So anecdotes and pilot data, but not solid proof yet.
Exactly. There are interesting case studies, that pilot program, potential links to FMS or ISSHL, but we desperately need more rigorous scientific research, ideally RCTs, to really know if, when, and for whom HBOT is truly effective and safe for Lyme-related conditions.
And until then, it seems like any perceived benefit for those lingering PTLD symptoms could potentially be a placebo effect.
We simply can't rule that out without better data. A strong placebo response is common in conditions with subjective symptoms like fatigue and pain. So until we have more robust evidence, HBOT has to be considered investigational for all forms of Lyme disease presentation.
Okay.
And we definitely need more investigation into using HBOT for these non-specific symptoms often attributed to CLD, especially since many of those symptoms are common in the general population anyway. Scientifically, remember, only Lyme recurrence getting infected again has been confirmed, not a chronic active infection persisting after treatment causing PTLD.
It's certainly been a complex topic to unravel. Thanks for walking us through all the
You're
nuances.
welcome. It's important to understand the different layers.
It really is. And it leaves us, and you, our listener, with a final thought to mull over. Given all these complexities, the diagnostic uncertainties, the treatment debates, the strong patient advocacy, how can patients and doctors best navigate this really challenging landscape around Lyme and persistent symptoms when clear answers are still missing? And what role should patient experience and advocacy play in guiding future research and shaping treatment approaches? Something to think about long after this deep dive ends.